you very much for joining us for this consultation on enhancing good mental health in Africa. My name is Grace Mwaura. I work at the African Academy of Sciences, where I manage a program on setting priorities for the African continent. And this evening, I'm looking forward to engaging with the fantastic speakers you can see on your screen right now. And I won't be introducing them for now because my work is to briefly tell you how this webinar is going to run. So allow me to give you a few instructions about today. One is that you will remain muted throughout the webinar unless, apart from when we move to the breakout sessions. During that time, you can unmute yourself and you can have conversations with other attendees in that webinar. Please make use of the chat box to ask any questions, to contribute anything that you wish to contribute to this conversation. We really love to hear from all of you because you're experts in one way or another. But also the conversation about good mental health in Africa is so critical, so we need to hear all your views. When asking questions, we highly encourage you to mention who you are and what institution you're coming from so that we can also connect with you at that level. Please feel free to interact with us using the hashtag that we have provided there, tweet about the event and post to your other colleagues out there. So at this point, I will hand over to my colleague at the African Academy of Sciences who will officially welcome us to the webinar, give us a few details about the webinar before we move on to the moderator. But before I do that, let me just emphasize the objective of this webinar. Our objective is to convene you with the aim of identifying critical gaps in mental health that can actually become action points for different stakeholders, could be donors, governments, our institutions at a global level, but also at a regional level. So we're really asking for you to contribute to this dialogue through the presentations, asking questions, sharing your own experiences, but also emailing us later on after we have had this conversation. So at this point, allow me to hand over to the Deputy Director of Programs, Dr. Alphonsus Nemba, who will welcome us and introduce the moderators for today. Over to you, Alphonsus.
Good evening, everyone, and good afternoon or good morning, wherever you may be joining in. It's my pleasure to welcome you to the Virtual Academy of Sciences. Let me continue with a bit of introduction about the African Academy of Sciences. Established in 1985, it is an academy of all sciences and the only continental academy in Africa. It draws from all fields of knowledge and recruits members who are the most eminent scientists on the continent. Again, it draws recognition and support from African governments, from the AU, and major international funding partners. In 2015, the AS launched the ISA platform, which is an innovative agenda setting and programmatic platform designed to shift the center of gravity for funding African science to the continent. As you can see on this slide, we have about 5 thematic areas which guide the work that we do. And these are natural sciences, social sciences, policy and government, environment and climate change, health and well-being. Next. So for the next 5 years, the African Academy of Sciences and NEPAD, AUDA NEPAD are taking increasing attention to try to set up an agenda that would lead to projects that have the greatest potential to drive transformational change on the continent. This particular agenda is guided by about 5, which are to engage the scientific community and key policy stakeholders on the continent, to publish position papers, disseminate and popularize the scientific priorities beyond the scientific community, to promote evidence-based policy making, and to inform investment decisions that would focus on major actors and governments and ensure resources are directed at critical gaps to influence development on the continent. Next. So our work in setting priorities, considering that there are a lot of needs and challenges in various developmental areas on the continent within the context of very limited resources, we've identified about 9 key priority areas in this in scientific research that we want to focus on. So we have had a first wave of scientific priorities, which are genomics and precision medicine, maternal and neonatal child health, and then climate change. The second wave has included food security and nutrition, data and biospecimen governance, and epidemic preparedness. Next one. And then the third wave, which we are currently busy with, includes gender and science, fourth industrial revolution, and mental health. You would find out that most of these priority areas, they already are within areas of our work within the academy, but also include new areas like the fourth industrial revolution. I would therefore like to invite Professor Bashiru Bonfo, who is a member of the African Academy of Sciences, or a fellow of the African Academy of Sciences, and also chair of the good mental health committee for the African Academy of Sciences. Professor Bonfo, over to you.
Okay, good afternoon, everybody. Thanks, Alphonsus, for introducing me. Greeting from Cote d'Ivoire. Before saying anything, I would like to thank the African Academy of Sciences for driving this important and timely identified agenda on mental health. For your information, I'm not a psychologist nor a specialist in mental health. I'm a veterinary epidemiologist and the director of one of the consortium funded by the African Academy of Science on building the capacity in One Health. So as Alphonsus mentioned, I'm a fellow of African Academy of Science, and I have been engaged into the fellows group on mental health following the African Academy of Sciences initiation of the Bongani Declaration on Accelerated Response to Mental Illness for Improved Health and Well-Being. So as you see, mental health is not only dealing with the global population, but we also want to drive that in the scientific community following our colleague who passed away in South Africa. So that was the time I have started thinking on how we can drive this agenda forward. That's why our consortium following this has established a joint case study with Amari, headed by Professor Dixon Chibanda, with the work targeting livestock-dependent population, example, the pastoralists. And as a practitioner in the past and a scientist now, I have witnessed depression and suicide during epidemics and drought in the Sahel. And I also seen this kind of problem in most of our scientific colleagues. That's why I was really keen to look into that end and see how we can use the One Health concept that we have developed so far to understand the main determinant and all the practices that are going on non-communicable diseases, including mental health. So we are aware that there are many expertise and initiatives going in Africa. That's why we want to identify the value of these existing comparative advantages to address gaps and area of concern for the next Pan-African strategy on mental health. And I think this is one of the main reasons of this meeting. And I would like to invite our other colleagues, fellows from the African Academy of Sciences to join the group so that we can reflect on and take the agenda from what will be given here in this meeting. I would like to thank you for your attention over now from my side and give the floor to Dixon Chibanda.
Thank you very much, Basiru. It has been an honor to actually work with Afrique One and to co-supervise Francis, and I'm really excited that he will be presenting this afternoon. I have 3 brief statements to share just to set the tone for this meeting. Can I have my first slide, Grace? In essence, when it comes to mental health, according to the World Health Organization, in Africa, 90% of those needing care have no access to evidence-based treatment. And this is one of the reasons why within the area of mental health, there's a lot of violation of basic rights of people living with mental, neurological, and substance use disorders. So we have a huge problem in Africa, and there's a need for solutions which are homegrown, solutions which truly narrow the treatment gap or reduce that treatment gap and enable as many people as possible to get evidence-based treatment. The other message I want to share is the fact, can I have the next slide? Thank you, is the fact that Africa is young. This slide shows you population size by region. And as you can see, Africa is the only continent where the population of young people is still growing. And so young people are actually disproportionately affected by mental health issues in Africa. And so our interventions have to specifically target young people. That's not to say we should not be targeting older people and others. It's still important to target them, but this is a particularly important group that requires attention, which has been neglected for some time. Can I have the third slide? And I'd like to end by challenging everyone to think outside the box. This is a recent publication from Oye Goreje, who is from Nigeria. It's a cluster randomized controlled trial, which actually shows that it is possible, for instance, for us to work with traditional and faith healers within the primary healthcare context and actually address a huge problem which affects most African countries, which is psychosis. So my challenge today, as we listen to the different speakers and eventually get into our groups, is for us to think outside the box in terms of what solutions would best work for Africa in terms of narrowing that treatment gap for mental, neurological, and substance use disorders. I'll stop there. Thank you. And so now I'd like to invite Francis from Afrique One to present. And I was honored to co-supervise Francis together with Basiru, who carried out some very interesting research as part of the Deltas One program. Over to you, Francis.
Thank you, Dixon, and good afternoon to you all. I'm glad to share with you today how the low performance of veterinary services is driving the poor mental health of livestock-dependent populations in Africa. The next slide, please. Across Africa, livestock farming and agriculture contribute significantly to the economies of many countries. And this provides livelihoods to farmers as well as supporting the local economy. However, when you look at the livestock belt across the continent, which is the Sahel region, the activities are threatened by the negative effects of climate change as well as political instability. And this is driving movement of pastoralists across the regions to areas that have better productivity levels that will support their ventures. However, these negative activities of climate change leading to droughts, political instability are threatening their production levels and contributing to the high levels of food insecurity on the continent. Next slide. Yes, so with this in mind, and with the basis of the One Health concept developed by Africa Aspire, we try to assess how these environmental factors owing to climate change influence production levels. So we try to look at the losses of animals suffered by farmers and factors accounting for those. And then using the One Health concept, we focus on mental health because we observed in certain publications that agriculture remains one of the highest occupations associated with high rates of suicide. So with the support of Amari, we put together this study. Now, next slide. So our study, next slide, yes. Our findings, this study was conducted in Ghana and we had certain concerning findings. The major thing we observed was that the levels of mental health of the farmers were high levels of poor mental health, as in presence of high levels of depression, stress, and anxiety. And these were in about 60% of the study population that we conducted this study on. And this is very high compared to the levels of mental health in Ghana. And the factors that we saw that accounted for these high levels of poor mental health were the losses of animals that are affecting the farmers. So when you take 9 out of every 10 farmers, they lost their animal within a 1 year period. And the major driver of these losses were livestock diseases, which is due to the fact that farmers were not getting adequate veterinary support. There was lack of preventive services. And all these were contributing to farmers treating their animals themselves with drugs that we could not account for their authenticity. Next slide. And also we observed certain structural problems. The livestock farmers, often to avoid confrontation with other land users, crop farmers and others, are relocating to very secluded areas in the communities where they do not have access to social services like schools, health services. And also, even though they are secluding themselves, there are also incidents of reported conflict with crop farmers and over land use. And these are leading to killing of animals, slaughtering of farmers and other things. And these have been reported widely in the news in Ghana. And also fueling the stigmatization of these livestock farmers. Next slide. So we also observed that the adaptation of farmers to the lack of veterinary services is leading to the proliferation of fake drugs and also self-medication. And this could pose a huge risk towards the development of antimicrobial resistance on the continent. Farmers also were selling their diseased animals to be able to recover their losses. And this can also lead to certain foodborne outbreaks. Next slide. So based on this, we try to see how we can address the problem and address supply of veterinary services to farmers to also improve mental health using the One Health approach. So our suggestions were the improvement in preventive services like the vaccination for farmers, training of community workers to support the main veterinary stream, also training of farmers to identify critical ways that they can invest resources to get more benefits from their activities, and also adopting the friendship bench approach that Amari has introduced. Next slide. So with this in mind, we designed this study, which I'm currently pursuing at the Swiss TPH, Swiss Tropical Institute of Public Health, to assess some cost effectiveness. So there are several interventions that are ongoing to look at which ones we could focus more resources on, given the lack of resources on the continent. And also to look at the next phase of Africa and Aspire, which is the reach, to address some of these challenges. Thank you.
I'd now like to, thank you, Francis. I'd now like to invite Florence who is from the World Health Organization Regional Office, to share with us her thoughts on strengthening mental health systems during epidemics. Please, Florence, over to you. Florence, I think you are muted.
Yes, it takes a while. I think if they
now
could
you're
just
fine.
unmute,
Now you're fine.
Yes,
you're fine.
Just
Go
a bit
ahead.
ahead. Yeah, thank you. Thank you. So yes, I'm Florence Baingana. I'm a psychiatrist and public health specialist. I'm the regional advisor for mental health and substance use in the Africa region. Next slide, please. My presentation is on strengthening mental health services in Africa during epidemics. The outline is going to be that I'm going to talk about very quickly the state of mental health services in the Africa region, because that's where we start from, and then talk about the impact of complex emergencies on mental health systems, and then the opportunities that are presented by complex emergencies and some recommendations. Next slide, please. So I'm not going to dwell on this slide, but it just shows just how complex the continent of Africa is in relation to emergencies. 43 out of the 47 countries for the region that I provide support for are affected by COVID-19. And I'm sure most of you participating here are very familiar with that. We also have 2 countries that are still affected by Ebola virus disease, and there are 8 countries affected by humanitarian crisis. So anywhere where you see a color there, and as the color gets deeper, that's how complex it gets. So we'll move to the next slide, please. This one shows we have begun now some of the mental health services. This one is looking at policies and plans in the region compared to the rest of the world. I'm going to present data from MH Atlas, Mental Health Atlas, a WHO document. As you can see here, while it seems like a lot of countries say they have a standalone mental health policy or plan, we also know what the quality of those plans are. So 31 countries said they have standalone mental health policies, but 23 of them said they had updated them in the last 5 years. Next slide, please. This one is about legislation. So 19 of the countries reported back, African countries, and said they have a standalone mental health law. But of those 19, only 8 had actually updated the legislation in the last 5 years. So one example could be Sierra Leone, which has a standalone mental health act. It is actually still called the Lunacy Act, and it dates from 1800 and something. So really we have a long way to go. The next one, please. Next slide. Allocation of resources, this is very important because you cannot have strong mental health services unless you have the resources. So in the African countries, those that report human or financial resources are included in the health policy and plan at 26, and only 27% of them actually have resources allocated. Next slide, please. These two show government expenditure on mental health. You can see where Africa lies. It's almost, you can hardly see how much is allocated for government expenditure for mental health. It's 0.1. And the slide that is to the right, I mean the graph that is to the right, indicates for low-income countries how much is allocated to government hospitals. So if 0.02 is the mental health expenditure. It is the exact amount allocated to mental hospitals. So this means that nothing is going to the primary healthcare level, almost nothing is going to the community level, and this is a huge gap area. Next slide, please. The sources of payment. How do people pay for mental health services? Africa may not look too bad because it shows 57% of people where they are fully insured or at least pay 20% towards the cost of mental health services. But we all know very well that while the services in Africa may be free of charge, we actually pay out of pocket, usually under the table in the healthcare services. Next slide, please. I'm not going to dwell on this one too much, but you can see in both slides that we have an exponential rise of allocation to mental health that goes with the increase in GNI, gross national income. So as countries grow wealthier, they are much more willing then to allocate resources to mental health. So one thing that could be done is maybe we all work to see how, but it's also a two-way relationship, isn't it? Because if we don't address the mental health of the population, then it's very difficult for the countries to grow richer, to have a bigger GNI. And especially as we had even from the previous presentation. Next slide, please. So mental health beds is another important one that we need to think about, because as you can see in Africa, the number of mental health beds per 100,000 seems to be very low. And yet we are always being urged not to invest in the mental health institutions. So we are caught in a very tight place between the sea and the hard rock, as they say, because we hardly have the beds, and the quality of care within the hospitals is actually very poor. And yet we do have a severe shortage of mental health beds. I'm not going to dwell on this one, but we should move ahead to the next slide. The mental health workforce is an important one. Again, you can see where Africa is. Very, very low mental health workforce on the left-hand side. And who are these that make up the mental health workforce? On the right-hand side, we see that up to 0.7 of this population are psychiatrists. That seems to be good, isn't it? But then we also have an equal number of other paid mental health workers, and we don't know who these other paid mental health workers could be. Could they be the traditional healers? Could they be the faith healers? You know, could they be the paraprofessionals, the nursing aides, who are often the ones running a lot of activities in the mental health institutions? We also have gap areas where you hardly see any color for child, adolescent, psychiatrists, other specialists, doctors, so occupational therapists, but I will not dwell on that. We shall move on. We just have the distribution isn't so good. Next slide, please. So what are the impacts of complex emergencies on this healthcare system that I have described? One is we have competition for the scarce resources. When we have a mental health emergency, because there's better remuneration of the mental health personnel working in the emergency, that's where they tend to go. Because there's often insecurity, human resources often leave their workstations if we are talking conflicts. Even right now in the COVID, many health workers may have opted not to work if it is in an insecure, if they are not being properly protected. We also get drug shortages due to interrupted drug supply chains. Setting up of parallel systems. This happens where we have a lot of NGOs coming into the countries and setting up a system parallel to the government system. And this can be negative. It may set up a system that works very efficiently for that period of time, but will not continue beyond the emergency. The other one is flourishing of psychosocial workers, some with minimal training, no accreditation, and very often no regulation. So next slide, please. Next slide. The opportunities, because most of these complex emergencies do present opportunities, include better remuneration of emergency personnel. As I had mentioned earlier, INGOs, NGOs tend to pay much better. And even in an emergency like now, the one we are going through, people get allowances per night for traveling out, for doing this dangerous work that they do. There's also recognition of mental health and psychosocial support in the IASC guidelines. Often we have a mental health psychosocial pillar, so there's increased recognition. And right now in the pandemic, COVID pandemic, there has been an increased recognition of mental health and psychosocial needs. We have increased in number of INGOs and NGOs providing mental health services. Very often it leads to an increase to access and quality. When we had the floods and mudslides in Sierra Leone and we were reaching out to the communities, services were much closer to the communities. We actually found people who had severe psychotic disorders who had been in their communities and had never been able to access care. So sometimes that is what it does. And then there's the broader scope of mental health services. So often we go beyond just prescribing medication and we get into more the psychological treatments. Next slide, please. Next. So the recommendations are not very many, they are just 3. One is to look for the opportunity to build back better. How do we strengthen community and primary health care? Oh, not quite. Involvement of government health sector in the mental health psychosocial support technical working group or pillar. It's always important to involve the government sector because that's how you get to building back better. And then INGOs and NGOs should build the capacity of government and local health and mental health workers so that beyond the emergency, we would have a sustainable mental health system. So thank you very much.
Thank you, Florence. Really, thank you for that insightful presentation. Really sobering statistics about the state of mental health in Africa and the need for us to really think outside the box to come up with solutions. Thank you very much. And I'm sure this is really food for thought for all of us as we get ready to go to our group discussion. So there's a lot to discuss, as you can see, just from that presentation. I would now like to invite, sorry, I can't see the screen in terms of the next presenter, Grace. I can only see Florence's face. And
sorry about that, Dixon. Simon is going to share his screen. Simon, do you want to do that? Kindly go ahead.
Simon, please go ahead.
So I have shared the screen. Can you let me know whether you can see it?
Not yet, Simon.
Yeah, so I think for the interest of time, I will just continue. And I would like to start by thanking the African Academy of Sciences for giving me this opportunity. I'm very humbled to be together with the panel of speakers and look forward to the sessions of today. And I was asked to talk about my experiencing doing research on neuropsychiatric comorbidities of epilepsy. I am a clinical neuroscientist by training and by experience, and I think I'm working at very exciting moments when actually there is a shift and a transition from calling these mental health illnesses to calling them neuropsychiatric disorders, or like what the WHO likes calling it mental and neurological and substance use disorders. And the reason why I work on neuropsychiatric disorders is first because the psychiatrists who are in the room will admit that most of the patients that they usually see present together with the neurological conditions. And even ourselves on this side, when we are working on neurological conditions, including epilepsy, we often see these patients presenting with neuropsychiatric comorbidities. And we've been able to do some studies as a result, which have been able to show that there is a shared mechanism between mental health disorders and neuropsychiatric disorders. And I would like to give the first example of the concept of forced normalization. And psychiatrists will agree with me that whenever they used to deliver the electroconvulsive therapy, even if it is actually overtaken by time, it was like an induction of seizures electrically so that you can be able to manage the mental illness. And we've also been able to observe that if you are giving tricyclic antidepressants, then you may end up lowering the seizure threshold. And when you lower the seizure threshold, then you've activated a neurological disorder. And recently, we've started to see evidence for anti-epileptic drugs being given to the patients. They come in when they are normal, but the moment they are given some anti-epileptic medication, again, they develop psychiatric manifestations. So we've started to see a lot of agreement with this concept, and there are quite a lot of work that is supporting that. The first one being the current DSM-5, which is now minimizing the subcategories for some of the disorders because they are actually agreeing that the psychopathology underlying them could be the same. And they have also started to explicitly recognize comorbidities. Also, when we look back in 2007 at the Lancet Commission on Global Mental Health, there is a seminal paper that was on no health without mental health, which I know many of you are very familiar with. And they did not only look at mental health, but they comprehensively looked at other neurological comorbidities, including even neuroinfections, which I think is quite very encouraging. And recently, we've seen the World Health Organization now start to publish reports and action plans, not only on mental health disorders, but also on neurological disorders, specifically epilepsy, which is a condition that I personally work on. So over the last 30 years also in the field that I work of neuropsychiatry, we've seen a lot of evolution and growth. And I can actually group it into three. The first one is the formational stage. That is before the year 2000, when we only used to do very small bedside studies. And from the patients that were coming with neurological conditions, we were able to document some manifestation. But at that stage, we would really not have been able to understand the extent of the problem until the year 2000, at the turn of the century, when we were able to conduct community-based studies. And at this point, we started to see emerging population-based studies of neurodevelopmental disorders, studies of mental health problems in children, as well as studies of epilepsy. And I would call that period the growth stage of neuropsychiatry. And then recently, in the past 10 years, I would confidently say that we've now started to reach the maturity stage of neuropsychiatry, because we can now start to see studies on transcriptomics, metabolomics, as well as genomics. And this one is accelerating very fast. And we've also started to see innovative interventions for management of mental and neurological disorders being advocated for. And the reason why we've seen this growth and evolution, I would attribute it mostly to the strengthened research capacity locally here in Kenya and in Africa. And this has been happening at different levels, individual level, where we are seeing an emergence of psychologists who can be able to develop assessment tools for identifying mental health and neurological disorders. And we are also seeing a kind of emerging clinical epidemiologists who can be able now to design and come up with reliable figures for the extent of mental and neurological disorders in Africa, as well as an emergence of research leaders who are now taking leadership and directing research in neuroscience in Africa. So we'll continue to see institutional growth, whereby the structures have become very strengthened, which is now allowing and promoting the two-way collaborations, for example, between the northern countries and African countries. And we are also seeing the local agenda setting for priority research agenda being led by Africans. Where we are having a lot of gaps, and that is going to be our main focus today, is at the system level, where strategies and effective coordination across sectors and among governments, non-governmental organizations, the international actors, is still a very long way to go. And as I conclude, I would like to mention about things which have been happening at the international stage, which I think we have an opportunity to discuss today, the international conventions, resolutions, and action plans, and to bring your attention to the Sustainable Development Goals number 4, which talks about reducing premature mortality from non-communicable diseases. SDG number 5, which is about gender equality for all persons with disability. SDG number 10, which is about the reduction of inequality for persons with mental impairment or psychological disorders. And also the UN Convention of 2008 on the rights of persons with disability. And here in Africa, the African Union Agenda 2063, social protection policies. And obviously, what is our main focus for discussion today? The World Health Assembly resolutions, number 64.5, which focuses on mental, neurological, and substance use disorders, as well as the one for epilepsy, which is number 68.20. So I wanted to pose a question and probably ask you to think very closely as to why, despite the development of all these conventions, resolutions, and action plans, why there is very little gain in their implementations in African countries. And I came up with about 5 reasons why that is the case, and which will form the basis of our discussion today. And the first one is practical challenges of support and collaboration between the World Health Organization and the member states, for example, our countries where we come from, as well as the academic and technical agencies. Then there is also no political awareness. Sometimes governments are changing very rapidly. And when a new government comes and there is no updating about the action plans that were approved, then they may not be fully aware about them. And this is definitely going to affect resources. We also have a lack of empirical evidence. In case we don't have a lot of scientific studies on epidemiology, then we don't have the numbers to convince the government. And obviously the lack of habitual relations with the World Health Organization, especially with the local organizations. I'm quite very happy that I'm in a meeting today where we've listened from representatives of the World Health Organization. And again, concept of transparent process from resolution development to World Health Assembly adoption, which I strongly feel that should be involving the members, and it should be done in an open way so that each and every person can be able to contribute. So as I conclude, I'll probably say that there is no doubt that a new entity is obviously needed to ensure coordinated approach towards the implementation of these WHO action plans at regional and national level. And I'm hoping that that entity and that meeting is what we have today, and that we will have productive discussions. Thank you very much.
Thank you, Simon, for that well-articulated deep dive into neuropsychiatry, particularly the clinical aspects of some challenging neuropsychiatric conditions. Epilepsy is one of the big problems we face in Africa. People suffering from epilepsy face the brunt of most of the abuse that you would see amongst people with mental, neurological, and substance use disorders. Very important topic indeed. I'd now like to hand over to Professor Melanie Abbas from King's College, who I've been working with for quite some time, and she will share her thoughts on building capacity in mental health. What role can Northern partners play in the current phase of Black Lives Matter? Melanie, over to you.
Thank you, Dixon. And I hope people can hear me and see me. I have started my video. Can you hear me okay?
We can
Grace?
hear you. At the moment, we can see you fiddling with your hand.
Okay, I'm going to hold my phone up. Can you actually see me now?
Yes, I can see you. Yes, we can see you. Carry on.
Excellent. Excellent. Good evening and good day to everybody. Thank you very much indeed to the African Academy of Sciences for inviting me. This is a huge honor for me to speak today. and for giving me this very thought-provoking title. Just to introduce myself, I'm a British mixed-race psychiatrist. I did several years of my clinical and my global health research training in Zimbabwe. In the last 10 years, though, I've been working with Dixon, with many other colleagues, Walter Mangezi, Munya Madambiro, Prof. James Hakim, and others on research and research capacity building. So the title if I could have the next slide, I just thought it would be worth just saying just a few words first. So I'm going to just be talking very briefly about what is the Black Lives Matter movement, and then go on to a few slides on where I think Northern partners can work to contribute. So the Black Lives Matter movement began in 2013 after a jury in the United States acquitted the armed civilian who murdered a teenager, 17-year-old Trayvon Martin. And following police killings of unarmed Black people in the US in 2014 and 2015, Black Lives Matter became an international movement protesting both police brutality and the larger social structures built on anti-Black racism. Then, as many of you will know, this year, following the murders of George Floyd, Breonna Taylor, and Ahmaud Arbery, the BLM protests of 2020 have become the largest social movement in the history of the United States, as tens of millions of people have demanded an end to systemic racism. Next slide, please. Now, being based in the UK, then I was aware that a number of universities all over the UK, and I'm sure over the US as well, were questioning their own responses to the Black Lives Matter movement, and they were being criticised, actually. So a lot of statements that were coming out in support of the movement, but a lot of universities were actually being criticised for tokenistic support and failure to address systemic racism within academia. Next slide, please. So I have now a few slides addressing the specific question I was asked to talk about. What can Northern partners do to build capacity? I think the first thing I would say is not to reinvent the wheel. We have to learn from excellent examples. I learned from one of the best. That is Professor James Hakim. I was fortunate to be part of the Medical Education Partnership Initiative. And I think the US has really been very, very important in promoting, facilitating African-led research capacity building programs, of which MEPI was, to my knowledge, the first of its kind. And has continued to flourish, certainly in Zimbabwe, and I know in many other African countries. And there are a number of people within that, both in Africa and within the US, who were really absolutely visionary in the way that they, the way that MEPI was structured. So I do think we do need to reflect and learn about the great examples that have gone before. So the next slide, please. Thank you. I think I can see that. I think that we've heard already today some absolutely outstanding examples of innovative research. And this really speaks to my first point, is that in the North, we need to recognize African countries as places of opportunity for really groundbreaking, pioneering research, and not as places. I'm ashamed to say that a dean of the medical school where I work said to me once, you know, Melanie, we're not do-gooders here, in terms of something that I was involved in Zimbabwe, and I was absolutely appalled, because to me, you know, it's time for us to recognize African researchers as leaders, as colleagues, as partners, as teachers, and as lifelong friends. And we really have so much to benefit Northern universities from partnering with African researchers and research institutions. We also need to recognize the reward of supervising African early career researchers. I certainly have the most, you know, stimulating and stretching opportunities when I get to supervise the early career researchers coming up through African countries. I think the value of a country research focus, I think quite a lot of Northern researchers tend to do what in the old days, or maybe even we still think of as helicopter type global health, where they, you know, like to cover 6 countries. I think there's a huge amount to be gained from a depth going into having a country research focus. Because as you all know, many of you listening, you know, African countries, of course, differ hugely and regions within them differ. And I think to make a genuine and authentic contribution, a country research focus should be advocated. There's a term that's cropping up more, which I think is something that we're going to hear more of, is about being an authentic ally, which is really about not seeing yourself as a Northern partner as some kind of, you know, a savior or there just to help. No, to be there to stand alongside, to walk alongside, to champion, and to show that commitment to and huge respect, and recognizing it as a privilege to work in another country. Can we have the next slide, please? I think this slide is almost redundant. We've already heard today some really exciting examples, but there are so many research opportunities. So that was just my first point on the previous slide, but you know, many African settings provide, someone's sending me a nice message here, incredible diversity for research participant populations. You know, populations that are less available in the North, for instance, drug-naive populations, people who face particular types of social determinants, heterosexual women living with HIV. You know, there are so many populations, and the genetic diversity within African countries is so vast and so rich. And yet, as you all know, you know, 90% of the work on genetics has been done outside the continent. So there are so many opportunities from genetics, neuroscience to, as Dixon said, testing if and how interventions work, thinking outside the box. I loved your example, Dixon, of the faith-based mental health programs. You know, this is such an obvious topic, and yet somehow in the North we're kind of scared of working with faith-based providers. And it's great that an African researcher has stood up and said, you know, this is time to do this. Next slide, please. So there's a lot that has to change. I'm very fortunate to work alongside under our Vice Principal International at King's College London, Prof. Funmi Alona-Sarkin, who is really, you know, leading the way at King's really and helping to pioneer the changes that have to make. They are big, they are really big. You know, we have to acknowledge the structural racism in our own back doors. We have to make pledges about fighting and not reinforcing racial and national hierarchies and exploitative systems. We have to find a way to acknowledge the relative privilege for those identified as part of the white ethnic minority, and also from the global North, that we have privilege that we have over students and colleagues who are Black, Asian, minority ethnic, and from low and middle income countries. And we seriously have to decolonize our curriculum. And you know, when we think of culture, we have so much to learn from African countries in terms of cultural difference. I noticed one of the speakers, one of the people in the audience today, Ben Weabong from Ghana. You know, whenever I teach students about cross-cultural methods, I use Ben's research. I don't want to embarrass you, Ben, but you know, as an example of exemplary cross-cultural research that everybody has to learn from across the globe. And I do think we have to make sure that we promote and show fantastic examples of African leadership in mental health. Obviously, culture is absolutely critical, understanding terminology and ideas and perceptions. And this is, I think, a way we can start to decolonize the global mental health curriculum by bringing these examples of really pioneering work by Africans from within Africa. And we also have to acknowledge the critical value of diversity as part of all research. You know, if we want to reach the populations that Florence has been talking about today, who are victims of epidemics, if we're wanting to promote and be role models for our students, we must have diverse teams, we must work with diverse research populations. So we have to acknowledge that, and that will, I think, help us to reach out and recognize what a privilege it would be for Northern Partners to work more with African institutions. Next slide, please. So what has to change? I think within Northern institutions, we have to allow researchers time to form partnerships and to mentor early career African researchers. There's a real concept, I think, in the US, which is the journey traveled, you know, where people have not had opportunities for mentorship, then it is going to take them longer to get used to writing academic papers, to to see themselves as able to, many of you know the process of what it's like to submit a paper, we have to allow time to mentor the young researchers to come up and to go through these processes. And we have to allow time for long-term investment in country partnerships. I think we need a lot more respect for the skill set of capacity building. It's not just altruism. This is an academic discipline, and this again is a partnership. I'm hoping that my colleague Walter Mangesi may be on this webinar. You know, Walter has done so much through Amari, which a lot of people from King's have benefited from. We have to do this as a partnership when we build capacity, and we have to learn how to publish on capacity building, and to show that this is actually something to be, this is an academic discipline. I think we need awareness across partnerships of the systems we each work in and the metrics we are judged by. The metrics are very, very tough in a lot of Northern institutions. You know, your grant income, your number of PhD students registered at your own university, your first author status on papers. We need awareness when we work with partners in other countries, but we also have to advocate for change in those performance metrics, so that there's more sharing and more recognition that, if a grant is 5 million but only 30,000 is coming to one of the Northern institutions, that is not something human resources saying to me, oh, that's disappointing, that's not very much coming to the Northern institution. No, but actually that's not the point. You know, this is of course it's not the point. This is a huge grant. This is going to have big impact, but we need to advocate for our own institutions to recognise this. And we do need more global health oriented departments to help us to facilitate this kind of work that does take time and involve travel and time for nurturing relationships. I think next slide should be nearly the last. Oh yeah, just to say one word about Amari, led by Dixon, the African Mental Health Research Initiative, that has been funded by the African Academy of Sciences. So we're coming to the end of 5 years with a network. Next slide, please. A network of 50 fellows at master's, PhD, and postdoc level across 4 African countries. And this is just one example of where we have worked with our early career researchers to help them to become more strategic about their careers. And we were very fortunate there that we were able to learn from a course that had been actually given to mid and senior career researchers in London. And we said, well, let's adapt that. Let's make this available to our early career researchers across these 4 African countries. And as I said, helping them to become more strategic, to become, to learn about peer mentoring, developmental mentoring. Next slide, please. And we called this course the ACEs course, academic competencies, a lot of work on writing skills and self-development, work-life balance, and thinking about personalities, their personalities, and bringing them more self-awareness, and also helping them to engage in terms of their digital engagement, and engagement with teachers and policymakers. Thank you. Last slide, please, I think. So there are many people from whom I have learned so much in Zimbabwe, and some of them, like Dr. Madambiro, Dr. Mangezi, are not on this slide. Dr. Jane Mutambirwa, an anthropologist, and Dr. Sekaini Watiwa. But I particularly wanted to highlight James Hakim and Dixon Chibanda, and 4 women. I'm very pleased to see that AAS is really promoting gender and science. So the 3 young women at the bottom are the early career researchers, who I think, as Dixon said, African youth is a very important theme for us to be aware of. And I think there are a lot of incredible young women researchers coming up who are going to be the leaders of the future. So thank you very much.
So our first question was on the real burden of mental, neurological, and substance use disorders in the overall population of Africa as compared to other pathologies. The main point that came up was that the burden of mental health is high, especially among our university students. And what makes matters worse is that it's highly unreported. We've seen that different experts from different areas, for example, Uganda, Nigeria, are coming up with different methodologies to be able to tackle mental health among this kind of population. There's also a lot of stigma when it comes to mental health. This is worsened by less awareness, because most people think that mental health is a matter of witchcraft. Another point that came out is that there is less evidence when it comes to mental health. Still, there's not sufficient study across the continent that can provide enough data to inform mental health. We've also pointed out on population-based initiatives. If that could be looked into, then the burden of mental health can be tackled in Africa. On our second question, we were to look at the current existing gaps and emerging risk factors in mental health and neurological substance abuse. And the key points that came up are non-communicable diseases emerging in Africa, for example, epilepsy. We've also seen economic hardships. For example, what has been seen with the economic consequences that came from this pandemic, the COVID-19. Gender-based violence has also been a key point. Social media was also mentioned, and also less family involvement. Yeah, that is all.
Thank you very much, Group 1. Let's move to Group 2, Mary Beta. I'll allow other groups to give their comments in 3 minutes. Then Dixon, I'll hand over to you. Mary, please. Mary Beta. Host, you can unmute her in case she is on mute. Mary Beta.
Okay, I hope members can hear me. So Group 2 was talking about strategies that we can use to narrow the treatment gap, and the tools and methods that we can use to predict, detect, control, manage, and even promote mental well-being. So some of the strategies that were spoken about were integration of available evidence or available interventions into existing frameworks. And members suggested using strategies like low-cost interventions, for example, doing pulpit mental health, whereby people like religious leaders and the clergy who are already undergoing trainings on counseling, we can incorporate mental health training in their curriculums, and also training people who are not in the healthcare systems, like teachers, and even training people at family levels to be able to detect these disorders. Another strategy was, our members discussed about how we can come up with interventions that are community oriented, and members noted that although Africa is very heterogeneous, we also have very strong cultural ties. So thinking about interventions that we can work on collaboratively across the continent. For example, the concept of partnering with faith healers and traditional health practitioners for mental health promotion is something that can be implemented across different settings. And also another strategy was actually a review of the tools that we are currently using to detect and manage mental health. And members suggested that we need to think about how we can make this more contextually relevant or appropriate. And another strategy was actually mental health literacy, promotion of mental health literacy, especially among these people who we are identifying as gatekeepers of mental health, the traditional health practitioners, the clergy, even people in the community or family members of people with these disorders. And then also members talked about using peer support systems to promote mental health, particularly among the youth. And I think I have already mentioned collaboration definitely between alternative healthcare providers and the mainstream healthcare providers, just to bridge the gap by including culture and traditions in the understanding of mental health. And lastly, there was also the mention of use of technology to promote mental health, particularly among the youth. That's all we had.
Thanks very much. Let's move to Group 3. And Changui, kindly speak to us for 2 to 3 minutes. Over to you. Host, kindly unmute Changui Munung. You will need to unmute yourself. Yes, kindly.
Great. So in Group 3, we discussed the role and legitimacy of African traditions, cultures, and religion in mitigating mental, neurological, and substance use disorders. So we had 3 main points. The first was understanding how mental, neurological, and substance use disorders are generally conceptualized. in African settings, and particularly taking note of the role of language and how this information could be harnessed to inform care that is often provided by traditional and faith-based healers, including the implications that the language and how it is conceptualized has implications for diagnosis and the introduction of new interventions. The second point was the role of family caregivers, and it was discussed that usually persons with mental and neurological disorders are often cared for by family members. It's seen as an obligation, but it will be important to see how this group of persons could inform community healthcare interventions for MNS. The third main point was the need to identify models for engaging faith-based and traditional healers in providing care for persons with mental health conditions. We had someone share the experience of South Africa, where they are currently integrating the role of traditional healers in providing care, and where traditional healers are actually, so they're formalizing that practice, and they actually can provide, give referrals to clinics. I also mentioned the need to train traditional and faith-based healers to provide psychosocial care and support for persons with MNS, and the third point was the need for open engagement with traditional healers and faith-based healers, and to build trust between them and healthcare workers. So there is need to identify models of how to engage them in ways that they see their contributions as important, and that the healthcare workers are not actually talking down on them. And the last point for that was to build a knowledge base where you can share information between traditional healers, faith-based healers, and healthcare workers. So those are the main things for group 3.
Thanks very much. Group 4, Simon and Davis, kindly let us know, or whoever is presenting can proceed. Simon and Davis.
Yeah, thank you very much, Grace, for this opportunity. The group has actually asked me to make the presentation for them, and these were our deliberations. So the first one was need to develop a national awareness program on mental health, and this is in twofold. The first one is for creating awareness with the government on the existing resolutions, conventions, as well as action plans developed by international organizations, and also specifically creating awareness about mental health in the communities, which we felt that it can reduce the incidence of suicide in those regions. And then the second recommendation was the need for developing national strategic plan for mental health. And this can actually be done in the form of a task force that includes all stakeholders on board. And the next one was the fact that we feel there is need for more empirical evidence, especially on the association between mental health and non-communicable diseases. And we can do this in 2 ways. First of all, through epidemiological studies, if they are funded, or through a situation analysis, just to see, as the situation is, how many people come to the hospital with the mental health caused by non-communicable diseases. And then the next one is to lobby the government for more funding, probably from increasing the proportion of the GDP, the gross domestic product, that goes towards mental health, that we felt this is going to strengthen the health system and also to build capacity with regard to the human resource. And again, also engage the government, especially on the issue of developing laws and legislations, and probably even considering amending policies and laws that have actually been in existence for long and are outdated, so that they can protect the rights of people with mental health disorders. And then we discussed about the possibility and need for a comprehensive care plan, or rather intersectoral collaboration, as well as integration of care, whereby we have different disciplines and specializations working together so that the needs of the patients with mental health conditions can be addressed comprehensively. And finally, as we will conclude, we felt the need for the involvement of the lay people in the community and lay practitioners, including the traditional health practitioners as well as the community health volunteers. And the group felt that these people can be able to provide psychosocial support. And for them to be motivated, the government may need to consider compensating them for their services. Thank you very much.
Sorry, I was on mute. Thanks very much, Simon, for that. Let's move to the final group before I head back to Dixon. Claire, kindly present for group 5. And we'll try, you're on mute already, so kindly unmute yourself and speak.
Great, thank you, Grace, and hi, everyone. So our group was pretty optimistic. I think the word opportunity came up a number of times, which I think is a good sign. But we also, a few people also made the point that investment needs to follow these opportunities. So we had 6 main points that we were speaking about. Firstly, we spoke about social determinants and the need to tackle poverty post-COVID with financial support, improving living conditions, helping vulnerable people with support packages. So that was one of the main discussion points that we spoke about. And then along with that, we also spoke about the need to integrate a mental health response into responses that look at poverty and unemployment and supporting vulnerable people, and the possibility of using community networks and NGOs to distribute information about mental health, maybe train people on psychological first aid. So we spoke about that as well. We also spoke about mental health awareness and decreasing stigma. And the word opportunity came up quite a bit here. And also regarding not just common mental disorders or mental disorders in general, but also complicated grief and bereavement. And our group felt that influential community leaders, mental health care service users, healthcare workers, a number of people could be involved in interventions for this, for mental health awareness and decreasing stigma. And just making it clear that a mental health condition is not a lifelong, completely devastating sort of sentence. And then lastly, task sharing and evidence-based interventions came up in the context of community networks and NGOs, but also in the health system. But the point was raised that we definitely need to strengthen health systems to sustain such interventions. And we also spoke about telepsychiatry and that we need data, we need surveys, and we need to know what the psychological impact is of the pandemic. So that was in response to the first question. We really had a great discussion. So we didn't do too much when it comes to African resilience patterns for mental health. We did speak about a few examples and examples of interventions that have been successful in enhancing resilience, but we didn't actually get to that one, and I think we needed more time. So thank you.
Thanks very much, Claire. Dixon, do you want to respond to that and take us to the next step? Over to you.
Thank you. Well, how much time do we actually have, Grace?
So we are already 6 minutes past the hour. If our participants allow us, we could perhaps take the next 15 minutes to wrap up, 10 to 15 minutes, I would say.
All right. So, yeah, so firstly, I'd just like to thank everyone. Really, this has been a wonderful afternoon in terms of getting ideas from all of you about what we can collectively do. And firstly, I also want to thank the African Academy of Science for hosting this event. As you may have read from the invitation, we are going to really put together a document based on your input, based on the presentations that we have seen and heard this afternoon, as a starting point to really come up with an agenda for mental health for the continent, something which is going to be supported by the highest office in terms of the AU. You know, so these are some of the things that we will be working on after this meeting. Certainly, my group, which was Group 2, came up with amazing suggestions, and listening to the feedback from the other 4 groups, we really have come up with a wealth of information which we are going to put back in a solid, convincing document. I would like to ask my colleague Basiru, who I have worked closely with over the past couple of weeks, together with Grace and her team, putting together this webinar. I'd like to ask Basiru maybe to come in with some remarks before we, you know, we ask you, Grace, to maybe say a couple of things in terms of next steps. Maybe you want to go into more detail.
Okay, thank you, Dixon. I would like to thank also the speakers and all the participants. I have looked at the participation with 150 invitees at the beginning. I think we are now around more than 50, which is a good number with the group. I would like to thank you for the good ideas that we will package. And what we have learned here is the multiculturality of Africa that we need to take along, and the area of considering the interdisciplinary research in mental health is coming as a prominent feature. And another issue that in my group somebody highlighted is how we can use the new technologies to have platform to share, because in the case of mental health, not everybody want to expose him or herself, but through the new technology, people can share their concern. So it's very important. So for me, I think what we have is very good, and we'll package that, considering that this will be the African agenda. There are very scarce resources to be allocated in most of African priorities. So we will need to target specifically what we want to take forward. And this is very important to consider. So let me thank again the African Academy of Sciences for this initiative, Grace and all the team from the African Academy of Sciences, and my friend Francis, and for his presentation, and I wish him all the best for his PhD work. So Dixon, thank you again for co-sharing this meeting with me, and we really look forward, if we are successful for the next Delta, we will have a huge impact and take some of the ideas along. Thank you very much.
Thank you, Basiru. Grace, over to you.
Thanks very much, Basiru. Thanks very much, Dixon. And thank you very much to all our attendees. We actually had up to 78 attendees at one point. And I really want to appreciate the contribution that you have made to this conversation. As Alfonso mentioned, and I'm making these closing remarks on his behalf because he had to dash for another meeting. This work we are conducting at the African Academy of Sciences is part of a much bigger project where we are asking ourselves of the SDGs that we have of the Vision Agenda 2063 and STISA 2024. What are those scientific priorities that we need to bring to our policymakers, to our fathers, that we can accelerate the impact we can have with those? And mental health has been selected as one of those by the African Academy of Sciences. It's a honor to be working with the team of Dixon and Basiru on this particular prioritization exercise. Moving forward, all the conversations we have had today, the contributions that you have made, and you can keep posting those on the chat box. We'll bring this together. We'll do a further in-depth synthesis of what exists as far as mental health is concerned on the continent. And we'll come up with a document that will help us to have conversations with the right people so that we can move this agenda forward. So feel free to email us any additional information, and always be on the lookout for the communication that we bring back to you. At this point, I'd like us to close the webinar. But before we do that, I'd really like to thank the team here at the African Academy of Sciences. If you can show their names in the last slide, you'll see it's quite a large team. Some of them were present today. Tom and Isavani were not present because of the meetings that were ongoing with some of our partners. But many thanks to Olivia, to Gladys, to Davis, to Wycliffe, who have been our team in the background supporting you with the breakouts, with the recording and everything else. Truly appreciated. Thanks to you, Dixon and Basiru, for fantastic moderation. And keep in touch and take care of yourselves. Goodbye, everyone.